What I'm going to do today is to describe efforts to run the entire public sector, public services in the UK on the basis of a system of performance management. I plan to describe its successes and its limitations and the lessons that we can draw from it. There was a UK TV series called Yes Minister. I don't know, you're all too young to remember that, I understand. And whenever the civil servants disagreed with the minister, they described the minister's idea as being very brave. And there is a sense in which this initiative was very brave. It was inaugurated very deliberately by Tony Blair in 1997 when he came to power, and it carried on, as I'll explain, through to 2010 when the Labour Party was thrown out of government. But it was even failing before that, because Tony Blair was replaced by Gordon Brown as Prime Minister, and Gordon Brown did not have the same commitment to this, and so it was beginning to collapse even before. But I think there is, so I would say there is a lot to learn from this experience, but also some of it is good, some of it is bad, and I certainly would not recommend that you take everything that was done as being a good model for your services. Okay, so what I'm going to do, I'll give a bit of a background to this first of all. My background, actually I originally worked in local government and in general public services, but I moved into health quite frankly because there was always more research money in health than anywhere else, but also that's where I'm stuck. But I still have a passion for the other public services. I'm going to give this example then of hospital waiting times and how that was handled. I'm going to talk a little bit about why we think some targets might work and others don't. There is an issue about unintended consequences that I'll talk briefly about, and then some final thoughts on when and whether and how to make targets more effective. Whoa. So, the system that was put in place in 1997 was what were called public service agreements. These were every ministry at the national level was given a set of objectives, and the intention was to measure progress in meeting those objectives, and to hold ministers to account if they failed to do what they were asked to do. And of course, for service delivery ministries like health and education and police, that meant that those ministries in turn had to devolve those targets that they were set to the local service delivery and local municipalities and so on who were responsible for it. So this is the objective of this scheme. It was to give a clear sense of direction, to introduce a focus on delivering results, and also form a basis for, I guess, the sort of thing that KORA must be centrally interested in, which is to work out what is working and what is not. So a research base, and also to improve accountability to citizens. So this was an example. Every 3 years we had a spending review. This is the 2004 one, in which, as well as saying how much each ministry was getting in terms of budget, it also gave those ministries objectives for the next 3 years. And so the Department of Health objectives, in high level, the objectives they were given, no one could disagree with: to improve the health of the population, to improve health outcomes for people with long-term conditions, to improve access to services, in particular at that, and I shall talk more about that, but waiting times were a big problem in the UK then, and then improve the patient and the user experience. And then, I'm not going to go through these, but those 4 objectives then had lots of sub-objectives with metrics. And so there were about 20 targets that the Health Ministry had to make. And these were how they were listed. There were those 4 top-level objectives, and then some underneath that. And I'm going to focus on that objective there, which is improving access to services, and in particular this one of people waiting for hospital treatment. I mean, I ought to have looked before I came here. Is that an issue in Denmark at all? Is it a... It is? Yeah, okay. So there may be some interest for those of you who work in the health sector in the experience there. I'm going to leave the slides, so anyone who wants to look at them in more detail can, and I'm certainly not going to go through this. This one just gives the evolution of those waiting time targets over that period of public service agreements. And it started off with a very modest set of objectives, but it steadily increased so that in the end the objective was that no one should wait more than 18 weeks from GP referral to the specialist to actually having treatment in the hospital. So this is how in detail the targets developed. As I say, the early ones were really quite modest. Outpatient waiting time, half a year, 26 weeks at first. And then inpatient, a further potential 15 months, so that this could be a very long time, those early targets. It shows you how long a small number of people were waiting. But then it steadily improved, and then these 2 were combined into that 18-week target from first referral for an outpatient right through to eventual treatment. So how did the Ministry handle this? The Ministry recognised that the key to this was, of course, the local organisations who were doing the service delivery. So they had to get the hospitals and the local organisers of health services committed to these objectives. And the way they did this, which is highly controversial, was to rank every National Health Service organisation 0 to 3 stars. They said the objective was to inform the public about the local services. Actually, I don't think very many members of the public really cared about these overall ratings. What they cared about was their specific treatment. So I think the bigger objective was to actually discipline the organisations into meeting these targets. So it's more of a hierarchical instruction. The star rating itself was quite a complicated calculation. I'll just give a few details on that. And the organisations with the higher scores were given more freedom. But also, the jobs of the chief executives in the poorer performers, I hope there are no chief executives here today. I'm not advocating this, let me be clear, but this is what happened, that their jobs were put at risk if they had consistently poor ratings. So those are the 4 levels. And this is just one set of targets. They changed over the period that these were used. But these were the 10 criteria, the main criteria in 2004. So if you were a hospital, this is how your performance would be rated. So no patients waiting more than 12 hours for emergency admission, no patient with suspected cancer waiting more than 2 weeks, and so on. And if you look down to number 7, that's the first outpatient appointment was 21 weeks. Over the year it reduced to 17 weeks, and then number 8 was the inpatient admission for treatment. So these were the metrics that we used. They were combined using a very complicated formula into a single star rating. And this was a typical one. This is my local hospital, and this gives all the various performance indicators. And in this year, that hospital was given 3 stars on the basis of all these indicators, and that was what the ministry put on the web for that hospital. So that's just the remainder of that scorecard. And the minister, a man called Milburn at the time, this is called naming and shaming. So he set out that list of star ratings with the very best on the left-hand side, the very worst on the right-hand side, which you can't see. And he called in the chief executives and told them if they did not improve within 12 weeks, their jobs would be at risk. And this was really, it was ultimately called Targets and Terror, because it was very, very stark. And it worked. It worked in a narrow sense anyway. Let me explain this chart. This gives the evolution of waiting times in England from 1995 to 2010. And it shows these are the people waiting 0 to 3 months for admission, and then 4 to 6 months is the red, and so on. And you see at the top there were people waiting over 16 months in 1997, which was especially bad, but that steadily, once these targets were introduced, and they were introduced in earnest around about here, those long waits disappeared, and it happened pretty quickly. So, incidentally, the other thing is, when the targets were stopped, there was no further improvement. You could argue there wasn't much improvement to go, but you can see that stop very clearly in the data there. That's when the target's finished. And this was the median waiting time for admission. At the start of, in 1992, the median waiting time was 15 weeks, and by 2009, it was just 4 weeks. So, you know, really big improvements. And I think my own view is the popularity of our National Health Service has increased very strongly over this period, and I think it's in large part due to this. Even though the number of people involved, number of patients who have benefited from this is probably quite small. I think it's more about how people perceive the quality of the service. I mentioned that it was abolished. This is the 18-week target, which is still in place. It gives the numbers who achieve their final treatment within 18 weeks after a general practitioner has referred them. I guess the line that's useful to follow is the solid orange line, which shows the number of people who were admitted, the proportion of people who were admitted within the 18-week limit. And it went up very fast at the start of the period when that 18-week target was introduced. And it really became established in about 2009, and it's remained more or less solid, but you can see there is a slight, now that the target is not made so explicit, although the performance metric is still used, hospitals have come under increasing pressure on other fronts, particularly on financial fronts, so you can see that performance is beginning to decline towards the end of the period, when there was less emphasis on this target. This has been evaluated by economists and others, and this is just one example. These targets were put in place in England, but not in Scotland. So what these researchers did is compare what happened to waiting times in England and Scotland. And here the English waiting times are in red, the Scottish ones are in blue, and they conclude that the targets did have an impact on the English waiting times because those two curves converge, and England converged towards the Scottish level of performance. So that's the direct evaluation of this, but of course, as all of you involved in evaluation will know, very often the big issue is, were there side effects of this policy that were unwanted? And there were indeed, and in fact this became national headline news, some of these bad consequences. So I'm just going to mention three types of consequences, ignoring other objectives that were not in that list of targets, misrepresenting or cheating, as I think is a better word, by the organisations, and also gaming behaviour, that is, behaving so as to achieve the target rather than to do what's intended. So these are some of the national headlines that occurred at the time. I don't expect you'd think generally that public service targets would be headline news, but I can assure you that week after week there were headlines about these targets. And these are the sorts that occurred at one stage. This is the accident emergency targets on the right-hand side. This was saying that hospitals, you remember there was that target of having to admit a patient within 12 hours. And this was saying that some hospitals were not allowing patients into their accident departments because they couldn't admit them within 12 hours. And some were even reported to have tents outside the hospital where they and here, this was something I'll just show a bit more on, the fact that although waiting times were good in some hospitals, actually their quality of care was not so good, and the clinical quality was suffering. So these more headlines here, and this is specifically that last point. So, and actually in that year it happened that this is the 0-star hospitals here, had the lowest death rates, and the 3-star hospitals had the highest death rates after operations. But actually, when you put confidence intervals around them, there was really, in fact, that difference in any case disappeared in future years. It was just one of those statistical things. But, you know, it does make good headlines. And likewise, readmissions were worst in the number of people readmitted were highest in the 3-star hospitals. Actually, one hypothesis is that the 3-star hospitals maybe were dealing with the most complicated cases, and they were actually, so they had more readmissions, they had more mortality, because they were taking bigger risks. But you know, that's for another time. So the second issue was whether the data were being distorted. So there were lots of stories about waiting times being either misrecorded or distorted. For example, if a patient didn't attend their appointment, they were put to the back of the queue so that they didn't affect the waiting times. This is the sort of thing that was happening. The National Audit Office early in this did an audit of data and found some hospitals who were, without question, distorting their reporting, and some of the chief executives were asked to leave, but also more junior people had to leave their jobs because of that. It wasn't just health workers who were who were cheating. There were also credible reports about police distortions and head teachers and teachers distorting their exam results, which were also part of the system. Finally, this distortion of behaviour. Here's an example from ambulance services. This is the distribution of calls answered by an ambulance service. I'm afraid I don't know where in the country it was. There was a target that you had to get 70% of your emergency ambulance calls answered within 8 minutes. And this shows the distribution between 6 minutes and 9 minutes for this particular service. And you'll see there's no particular pattern. They didn't seem to. The 8 minutes makes no difference. It seems perfectly normal, as you'd expect, with the highest frequency less than 8 minutes. But here's an ambulance service where there does seem to be something happening at 8 minutes. For some reason, the number of calls over 8 minutes, it's not smoothly related to the number that are lower than 8 minutes. So there's a suspicion that something might be happening to the calls that take longer than 8 minutes in that one. And then there's another example where really something rather bad has happened there, because they're recording lots of calls taking precisely 8 minutes and then a drop after that. I have to say, sadly, the chief executive of that ambulance trust also lost their job. You wonder why anyone does these jobs now, but that's what happened there. Wasn't just it's a qualified success, I would say, and it demonstrates why you've got to have checks and balances with these target regimes. But here are some other apparent successes in other services. So here, this is exam results, and there were particular problems in some London schools with exam results. And so one thing I haven't mentioned, I'll come back to later on, is that in order to help ministries, they called it help, improve their performance, there was a Prime Minister's delivery unit, which you could argue was part of the terror regime, but they went in and visited areas that were not succeeding. And they went in to the London schools that were, the boroughs in London that were failing with their schools, and focusing on the targets, and they really secured some very big results. And indeed, London now has, there is a complaint that London's education system is so good that it's drawing away teachers from the rest of the country, and it's actually being bought at the expense of the rest of the country. And previously that was not the case. So there's a very big success, which is a mixture of the targets plus this delivery unit, improving school results in London. And the other one, which I'm afraid I don't know anything about, but the Institute of Government explains in some detail, was the institution that was responsible for asylum applications, and that too, which was a pretty scandalous performance early in the period. They actually went in, tried to work out why there were so many asylum seekers being handled in a very slow way, and they introduced lots of initiatives based on the target, improving the target, and that's again another example of major service improvements. But it wasn't all success, and In particular, I think I would point to the area of targets which were not the obvious responsibility of one ministry or one department. And I'm pretty sure that you'll have, in fact I was talking to Michael earlier, I'm sure you'll have some examples of this in your country. For example, care of the long-term elderly, long-term care of the elderly and frail goes across a number of ministries, a number of departments, probably a number of jurisdictions. So central and local government, regions and municipalities and so on. And I think this is where the real difficulties come into play. One of the examples here was, again in 2004, UK has a big problem with the rise in obesity, and particularly childhood obesity, and so there was a target there, and it was set as a joint target between the Department of Health, Department of Education, and the Department of Sport, essentially. And there was the target on the right-hand side. So the target was to reduce the prevalence of obesity amongst children. You can see how carefully it was specified. And it's measured by an annual survey that's done of the general population. But it really never got going. And there are issues about the fact that it's very difficult to see what those ministries should be doing. So there's a lack of instruments. The only instrument that I'm aware of that without question does something about obesity is one that I know Denmark has some experience of, which is taxation. And I don't know the story of your sugar tax, but I know you tried it. But there are very few other really evidence-based interventions, so that may be one of the reasons. But the other reason, the fundamental reason, which the National Audit Office focused on, was the fact that the three ministries, none of them really took control. They were, really, this isn't central to our business. We have other things to spend our money on, and we can't get the other ministries to pull their weight. So that was really, if you like, a failure on the targets regime. Very important objective, but even when you made it a fundamental objective of government, it was quite difficult because of the ministerial structure and also because of the lack of evidence base to do much about it. Going to skip over these. So I just wanted to focus a little bit more on why some of these targets fail and why some of them succeed. And I think fundamental to this is the fact that the organisations that are in charge of delivering the services actually really feel they have to be in control of whatever it is you're asking them to do. And this is a study some colleagues and I did a long time ago, but it still gives that story quite clearly, I hope anyway. So this again comes from the healthcare sector, and in those years, in the year in which we studied, the healthcare was organised, the ministry was in charge of it. It devolved most of its responsibilities to a number of regions, and then within the regions there were district administrations called district health authorities that were responsible for about 300,000 people that delivered it. And then underneath those districts, of course, are the individual communities. No administration here, but this is where people work and so on. And the green dots at the bottom are supposed to represent individuals. So what we tried to do was work out how much of the variation in performance could be attributed to these various levels. So if we looked at waiting times, which we discussed earlier, how much was the responsibility of the regions, how much of the districts, and how much was really just local variation. So the model we used, it was a fairly simple statistical model to try and get these regional effect, the district effect, and then the random effect at the bottom. And so we're trying to find what proportion of the variation in performance is due to organisations at these different levels. We just use some indicators that were available at that time. There's no real rationale for the indicators except for the fact they were universally available. So they might look a bit odd, but there were 3 on health status, that was life expectancy and so on, 2 on clinical quality, 4 on efficiency, and 5 on access, including waiting times. And these are the results. And what this graph shows is, first of all, the blue is the amount of variation that's attributable to the regional performance. The yellow is the variation that's attributable to those districts, the local administration. And then the green is just random fluctuation that these public services don't seem to have any influence over. And you'll see there are 2 extremes here, really. This is waiting time for surgery, and you'll see that's mainly attributable to the local district, probably actually the local hospital within that district. And that's the main determinant of that. So nearly over 75% of the variation is due either to the regional district administration, the public services. At the other extreme, when we take, this is the mortality rate, aged up to 75, only 8% of the mortality rate is within the control, is attributable to the local public services. So when you set targets, you would imagine that setting a target for waiting time is likely to have quite a lot of influence on managers because they feel they've got some control over it. Whereas, as was the case, setting a target on mortality is really, they will have trouble finding things they can do in that area. That's not to say that it's hopeless or anything, but you have to recognise there is a lot of randomness that is outside the control of the public services for these sorts of things. I could go through what these other ones mean, but in the interest of time I'm going to skip, but I hope you get the general idea. The other thing that's interesting there, I think, which may have some relevance to the Danish situation, is that the more local administration seems to have more direct control over these than the regional level, and that's a fairly consistent finding. So that really just recapitulates what I've just said. But of course, what we really want to know, the last point here, is what causes these variations and what we can do to help organisations actually make an influence on their services. So just to really conclude the talk, I'm going to just go through a number of more general lessons that I think can be learned from this English experience. And it is mainly England. As I said, for example, Scotland did not have the health targets. So why did it work? Or why at least did it work in some cases? I think partly because over the years the government learnt to be much more specific about its targets. It reduced the number from over 600 down to almost 100 over the period, which when it's spread across 20 ministries is not many. And in the start, they were long-term objectives, rather vague, and some of them were not quantified. but later on they became very specific and more quantifiable. And in the same way, the specification moved progressively away from a broad national ministry target towards ones for individual organisations. For example, in education, the focus wasn't just on getting the average attainment right, it was making sure that there were only a limited number of organisations that were performing poorly. So it was the distribution as well as the average. Number 3 there, I think this is fundamental to public services, which is that there were attempts, certainly it was true in the health sector, to engage health professionals in setting the targets. This is quite difficult because, of course, in some ways the targets are intended to challenge traditional ways of doing things. But at the same time, the professionals are very powerful across the public services. And my view is quite strongly that you at least need some leaders amongst them who really do accept what you're trying to do and try and take the rest of the profession with them. And I'll give as a counter-example our Justice Ministry, which did not engage the legal profession in its targets, which included trying to speed up the pace of justice in the UK, speed up the court process and so on. And it was very much a failure. And I would assign some of that to the fact there was no attempt to engage, at least I'm not aware of any attempt, to engage the legal profession in those targets. This was generally a time when the UK, it seems so long ago now, but the UK had a lot of money in the public services. And so there was capacity to help organisations transform themselves in towards, to be able to tackle these targets. And so, for example, one of the things the Prime Minister's delivery unit did was to target money at areas conditional on them improving their performance. And as we saw, there are some pretty concrete incentives attached to the targets. I think it's always difficult in public services to think about incentives because you clearly want some consistent level across the country. So do you really want to reward the good organisations with extra finance, but penalise the bad organisations with less finance, when actually the people who use those bad services are already suffering because of the bad services? Are you really planning to make it even worse by taking money away from them? So I think there are some problems there. But of course, you can target incentives at the managers and at others to try and help them improve, or persuade them to improve. So there were some things that needed to be in place for this, this thing to work. First of all, it needed the political commitment of the Prime Minister. And this was particularly Tony Blair's big thing in public services. And it was noticeable as soon as he went out of office how it fell out of favour. This distinguishes it from almost every other targets regime we had. I mean, I don't know about your health ministry, but our health ministry used to set target after target. You know, public health, we're going to improve deaths from stroke over the next 5 years and so on. These are like the Soviet Union 5-year plans. You know, they never had any traction. They were good processes to go through, but they had no direct impact on the local services. And I can give you lots of examples of that. So the difference here was that the Prime Minister was absolutely committed to it, and he wanted to see results. And because of that, this took a little bit of time to work out, but he set up this delivery organisation, the Prime Minister's delivery unit, to actually make this happen. This was really the Prime Minister by proxy. So they went into the badly performing and indeed the well-performing organisations. You need to targets, as I'll say right at the end, targets are really only good when you want to achieve change. But in order to check that they're not causing adverse consequences elsewhere, you've got to keep all your other monitoring and regulation devices going. So, for example, in health, it was really important that the quality of healthcare, the clinical quality, was monitored to check that it wasn't being adversely affected. You do need high-performing performance management skills in the ministries. Actually, our civil servants, at the start of this process, they were not really trained to think about service delivery. They were mainly trained to develop and deliver policy. And this was quite a shock for them, to start having to get local organisations to work, to do evaluation and so on. There was a need that was never really resolved for strong collaborative arrangements across ministries. I think that is really quite a difficult area. I have some ideas in theory about how this might be done. I know the former chief civil servant in the UK, Gus O'Donnell, or God as he was known, G-O-D. He was very committed to this, but when you said, well, maybe you've got to change the way your ministries are organised, so you have a ministry for obesity, he said, oh no, steady on. I don't mean quite that strong. So, you know, I think there are some conflicts there around how to handle this. There's clearly, there are tensions between central control and local democracy and local freedom to set their own priorities. And I think, of course, local government, I expect it's true in your country, gets some money from the nation as a whole, from the national government. So there's some accountability needed, but also local government is meaningless without some freedom to adopt its own policies. And that's a challenge, I think, within this. You've got to have this data audit and surveillance, really important, and you know, the sort of role that the regulators must do and national audit offices. And then this engagement with relevant stakeholders. It's quite a difficult thing. You certainly need engagement. Just imposing these things is no good. You've got to have some engagement. On the other hand, there's got to be some distance from some of these stakeholders, such as service users and the professionals, because part of the role of government is, of course, to trade off the varying demands of all of these stakeholders. How am I doing for time? Just a minute? Is that okay? Yeah. Okay, so there were some limitations of all of this, and I've alluded to most of them already. So targets were selective. Managers and practitioners may have ignored, in some domains, ignored things that were not targeted. The target system was very complex, and there is a concern that this sort of regime just, and I think that's ultimately really why it lost support. It's because it was getting very difficult, very complicated. There is the risk that it undermines the data on which all the public services rely. There may have been gaming in some areas, the tents outside the hospital. And something that I'm not aware is really being tested, but it's a big concern, is that actually these targets, they drive out the altruism of many public service workers, such as teachers, police officers and medical professionals. Instead of being altruistic and wanting to do good for their community, they have to look upwards to these targets. And I think there's a definite truth in that, but it's really quite a difficult thing to establish. So, finally, here, if any country or any administration were thinking of going in this direction, I guess the first thing I'd say is be careful. But at the same time, there are some benefits to it. So these are some principles that a report from the Social Market Foundation set out, which I think are fairly good principles. You should set a target only when you need to achieve change. Use a small number of targets. Try and focus on outcomes as much as possible. That is what you're ultimately trying to achieve. Outcomes are quite easy actually in the health sector. One of the reasons it's relatively easy to research is that the outcome is usually improved health. But in other sectors, for example education, it's quite difficult to see exactly what you're trying to achieve, and that can be problematic. So I would not be slavish about being focused on outcomes, but I think if you start to just measure the processes of services, you have to reckon those have got to be processes that you think will eventually do good for your service users. Targets are best when there are other mechanisms like service user choice. If they can choose a provider, maybe targets are less important. Sanctions and incentives should not be too strong and they should not be too weak. That's easy for an academic to say, it's much more difficult to do. They've got to be fully integrated into the whole performance management regime, in fact the whole of the public service delivery, and that can be quite difficult. Joint targets I've discussed being quite problematic. And finally, public satisfaction is a really important dimension of performance that is often underemphasised. And there's a feeling that there was not enough about that generally in the targets regime, and that it should be more widely used. As far as the content of the talk's concerned, that's more or less it. I just wanted to conclude by saying that I think actually more fundamental than targets, the core thing with public services is performance information. Performance information helps you establish, but by requiring performance information, it helps you to establish your priorities, quantify achievements, promote accountability, and secure improvement in those public services. But you do need to make sense of all that performance information. On its own, it's of limited usefulness. And this is where organisations like KORA, I'm sure, are centrally involved in trying to help governments, local administrations, the general public, the media, understand what all this means. It's a terribly important task. We also need to think about how all this work is going to be used. Is it for user choice, so they can make better choices? Is it purely for accountability, so citizens can vote for better government? These are important things that I think need to be established and are often not stated properly. And finally, even though you've got the performance information, you've got to line up everything else in your governance structures so that the performance information is aligned with your governance structures, with your service delivery, and so on. And most importantly, going back to the slide I showed you about how much control organisations have got over their services, it's really important that you focus the performance information on things an organisation can do something about. And I'll tell you one really cautionary tale, just to conclude. I was a member of the board of what I thought well, what was a highly successful organisation in the UK called the Audit Commission, which was responsible for auditing local institutions, hospitals, local government, and police forces, and so on. Audit not only the money, but also the performance. And it was an excellent organisation, did lots of good work. But I think, but it was abolished by the incoming government in 2010, the coalition government. Now, actually, this is being recorded, isn't it? So I can't tell you the real reason. It was abolished. But I would say one of the weaknesses that it pursued in its later years was that it tried to show the performance of all public services within an area. So it took a region or a locality and didn't say this is a responsibility of that organisation or that organisation. It just said this region has very good police services, has very bad social care and so on, without saying who was responsible. And I think that was a weakness that led to it being, largely it was more that it became irrelevant, rather than because, you know, it was distorting anything. So I think you have got to focus at the institutions in your performance information. So, once again, thank you for inviting me. I'd like to wish you all the very best in your ventures in improving public services and accountability. I think it's a fantastic venture. If I was starting my career now, KORA would be the sort of organisation I'd love to work in, and I wish you all the very best. Thank you very much.